So in this lecture we will discuss about different types of arrhythmias. So in this lecture we will discuss about atrial fibrillation and atrial flutter. Remaining will be discussed in the next lecture. So atrial fibrillation and atrial flutters. Atrial fibrillation basically means the atria, instead of contracting, it's just vibrating, or just some tremors are happening, not proper contraction. And why it's happening because of some re-entry circuits. Let me draw a diagram for you to show what's happening exactly in atrial fibrillation. So this, let us assume this is a heart. Okay, usually it is the SA node that fires and impulses go through AV node. But in case of atrial fibrillation, some re-entry tract happen around the pulmonary vein. We have got four pulmonary vein. So we have four re-entry tract. What do I mean by re-entry tract? Re-entry tract means, let us say a depolarization has started in this region. So this is depolarizing, positive, 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 positive. By the time this reaches this area, these areas has repolarized, which means this area is now negative. This area is now negative. Since this area is negative, this depolarization will again depolarizes this area. Again, when it reaches this area, these areas have repolarized. So this will, keep on happening. So this is called re-entry circuit, and when this is happening, some depolarization will happen in this direction, and multiple direction as well. All right, so that is what happening in atrial fibrillation. We have four re-entry circuit in atrial fibrillation over the left atria. So the people with this condition, they will have, if we take ECG of these people, they will have no P wave, no P wave in their ECG. Instead of P wave, we get something like this, a wavy baseline, and their heart rate would be irregular. Why their heart rate is irregular? Well, we don't have to go that much in detail. It is because, as I mentioned, there are four. There are four in retract, and one might be beating at the rate of 250. One might be generating impulse at the rate of 300. So it keeps on changing. The atrial activity will keeps on changing. When that changes, the number of impulses reaching the ventricle will changes. All right, if it's beating at the rate of 300 atria, 150 might reach the ventricle, and suddenly if the one with 250 is taking control, the atria will beat at the rate of 250. So maybe 130 or 140 will be the ventricular rate, pulse rate. So that is why we are getting irregular heartbeat, and irregular wave, irregular pulse rate, irregular rhythm. So that's about atrial fibrillation. No P waves, wavy baseline, and the RR interval is irregular in atrial fibrillation. Can you see here? You can see here. See here. The distance is keeps on changing, right? The RR interval, like, one is small, other is big. The interval. Well, let me show you one more ECG here. Okay, here we have four boxes, right? This is an R wave, this is an R wave. We have got one, two, three, this much here, this much over here. So we have got in total four box here. So let's take this side. Again, this is an R, this is an R wave. Here, one, two, three, four. We have almost five box over here. Again, if you take here, we have got only three. So there are three large box over here, here five, here four. So this is basically irregular interval means irregular heart rate. And other features like absent P wave. There is no P wave here. You may ask, what is this? This is T wave, guys. T wave will be the only T wave can be this much tall. If you have a confusion, there are two waves which is T and P. T wave will always be the taller one. Pick the taller one. That is going to be the T wave. The smaller one would be the P wave. Okay, so here in this case, it is these are T wave, and you can see here some fibrillatory waves. Okay, the wavy baseline, and the waves, even the fibrillatory waves, those are irregular, something like this. Not like flutter you get again wavy baseline, but those are like regular, like this. That is how flutter appear. Flutter baseline, here it's irregular wavy baseline. So again, and next is about management. Before going management, let me show you one more ECG that demonstrate atrial fibrillation. So this is another ECG of atrial fibrillation. You can see, let us take, okay, so what is the distance here? One, two, three, four, five large boxes, and we don't have here one. Okay, let's take here one, two, three, four, five, one, two, three, four, one, two. So basically, the RR interval is different, and we can't see any P wave here. It's just a wavy baseline, no P wave. So this is going to be atrial fibrillation. If you want, you can uh, calculate the heart rate and all, but we don't need that at this point of time. Okay, like it's very difficult, as I mentioned earlier. We need around 30 large boxes to calculate the heart rate if when the rhythm is irregular. Okay, now we will go to atrial flutter. Atrial flutter, let me show you. No, not this one. Yeah, this is atrial flutter. Atrial flutter, basically you get a kind of wavy baseline. This is not like a regular P. This is, a wavy baseline. Okay, and that would be regular because it's a single macro re-entry tract on the right atria, which basically means, assume this is the heart again. So instead of four re-entry tract, you know here we have only one re-entry tract. Since it is coming from the one re-entry tract, it will have one type of wave, one type of uh, flutter wave. That is why you are seeing here almost everything is almost same shape. Okay, that's about atrial flutter. Flutter can be regular in rhythm or irregular in rhythm. So yeah, that's it. Flutter. Just look for the flutter waves, guys. That's it. A rhythm can be regular or irregular, and it's also called sawtooth appearance. Yeah, that's it. Now it's not that important atrial flutter, and the management of atrial flutter and fibrillations are same. In atrial flutter and fibrillation, like this is the atria. Since there is no proper contraction of the atria, the blood can stagnate here in the right and left atria. The stagnation can leads to what? The stagnation can leads to thrombus formation. If thrombus has formed inside the left atria or left ventricle, it can come out through the aorta and reaches brain and can cause what? It can cause stroke. So we don't want this. So if we diagnose a patient with atrial fibrillation, first we will control the rate. Rate control means controlling the number of impulses going from atria to ventricle. We do this by giving some medications like beta blockers and calcium channel blockers. These are the two drugs we use. Well, there are other drugs also that can block the AV node like adenosine, but adenosine is having very short half-life, so it's not going to be useful for you to control the atrial fibrillation. Then uh, one of another drug that can block the AV node, uh, block the impulses at AV node, but no longer uses digoxin, because digoxin definitely it can block the AV node and control the number of impulses coming to ventricle. But the problem with digoxin is it will increases the automaticity of the heart, which means it will block here, it will block the AV node and control the number of impulses reaching the ventricle, but it will increases the automaticity of the heart, so the re-entry circuit will will become more faster, you know. So we don't want the re-entry to happen, so we don't use that. Okay, so that's about the okay. So before start, when we diagnose a patient with a patient atrial fibrillation, we calculate a score called this one. I don't know how to pronounce this. You can pronounce in your own way. Chart DS2 WASC score. So basically, after taking history from the patient, we will calculate the score. If the patient is having congestive heart failure, we give one. If he is having hypertension, we give one. Like that, we like that is for C for congestive heart failure, H for hypertension, A for age, that is more than 75, D for diabetes, S for stroke, TIA, something like that, V for vessel disease, vascular disease, A for again age, that is between 65 and 74, S for sex. Female sex is given an extra point. So we calculate, yeah, we calculate the score, and if the score uh, is more than 2 or more than or equal to 2 in a male, then we will start the anticoagulation. If it is more than 3 in a female, we start them on anticoagulation, because in female you have already given a score 1 because of their sex. So in female we need more than 3, more than or equal to 3 to start them on anticoagulant. If the score is 1 in a male patient, we can think of starting them on anticoagulant. It's not an indication, we can just think of starting them after discussing with consultant. Similarly, for female, if the score is 2, again we can think of starting them on anticoagulant, but it's not an indication again. But we will start them on oral anticoagulant on for sure if their score is more than or equal to 2 or more than or equal to 3 in female. All right, and we do also calculate a score called Hasbled score. I'm not sure how many of you heard of that. Actually, Hasbled score is used to assess bleeding risk before starting anticoagulation in atrial fibrillation. As you can see in the picture, we have hypertension, abnormal renal or liver function. Each has got 1 point. Maximum score is 9, and a score more than 3 indicate high bleeding risk. So if the patient has got high bleeding risk, we should closely monitor him, and we should control blood pressure, avoid unnecessary NSAIDs. So basically, we need to be more cautious when we start anticoagulation in these patients. So yes, we must do Hasbled score before we start anticoagulation in these patients. And next here, what is next? Okay, so okay, then that's it. We have finished the topic atrial fibrillation and flutter. Remember, if there is a atrial flutter, if they ask you the treatment, it's going to be beta blocker and anticoagulation to prevent a stroke. So yeah, we have. And one more thing, like I told you that if you are seeing a P wave, if you are not seeing any P wave, and if it is irregular the rhythm, then it is going to be if atrial fibrillation. But there is a case where you can get P wave and it's irregular. What is this case? You can see P waves and that is of different shape, and the rhythm is not regular. Rhythm is not regular. This is called multifocal atrial tachycardia, MFT. So what basically happening here is that if this is a heart, okay, instead of the stimulus, the here is the SA node. Usually the SA node fires. That is why we are having a regular heart rate, right? But in case of MFT, multifocal atrial tachycardia, different regions in the atria and ventricle, some areas in ventricle, they start firing. They start firing in their own rate. That is why you are getting irregular R. You are getting irregular R, right? You are getting this. This is big compared to this is small. The distance between R, or sorry, SS or the QRS complex. So the that is a reason why you are getting irregular heart rate, and moreover this different region, they depolarizes in different directions. When they send electrical signals, they send in different direction. Depolarization happen in different direction. So if this is a lead over here, this will record electrical activity in different direction. One is going this way and other is going this way. That is why you are getting the P wave that is of a different shape. Like some is like this and other is like this and another is inverted. So different shape of P wave, but irregular heart rate. So that is tachycardia multifocal tachycardia. So we have finished, and a few more details that I would like to add is that usually in this atrial flutters, sometimes it follows a pattern that is called 2 is to 1 pattern. Like a pattern, like a fixed pattern, maybe 2 flutter wave or 3 flutter wave, then 1 QRS complex. So or sometimes 2 flutter wave, then followed by a QRS complex. So this kind of pattern can be seen in flutters, or it can be one variable, sometimes 2 flutter wave and QRS followed by 3 flutter then QRS. So but fixed pattern is more common. All right. Then two more thing I would like to add is, in generally we use apixaban or rivaroxaban, that is direct oral anticoagulants, for treatment of atrial fibrillation, means anticoagulation for atrial fibrillation. But we use warfarin in some cases, like if the patient is having mitral stenosis along with atrial fibrillation, or the patient is having any artificial valves in the heart, then instead of using rivaroxaban or apixaban, we prefer warfarin. And that's it. And in the next lecture, we'll discuss about SVT and supraventricular tachycardia, ventricular tachycardia, fibrillation, torsade de pointes, all of things, all of this. Thank you.